everybody. This is Michael Munson with Forge. I am thrilled that so many of you are here with us tonight, and that Annie Lakatosh is here with us tonight to give us the lowdown on transmasculine hormones. I suppose the hormones are not really trans, but we'll talk about hormones. So I am going to be your host for the night. I am going to step back in just a second, but I wanted to make sure that we did a little bit of housekeeping before I go away. So the couple of things that y'all should know is that right now everybody's in a listen-only mode, except for the people that are presenting on the screen. So if you'd like to say something, we will have time for questions and answers later, and we can unmute you. And you can also send questions in the chat. So just to make sure that everybody can get to the chat, let us practice. What about typing in the first word that you think of, or the primary word that you think of when you hear testosterone? So find the chat. What do you think of when you hear the word testosterone? Facial hair, anger, interesting. Masculine. Sweaty, right? Moody, balance. A hormone. Shot, important. Yeah, all of those things. Yeah, perfect. A needed medication. Yep. We are going to talk about all of those things. Actually, Annie's going to talk about all of those things, I'm sure. There's a question that is it going to be recorded tonight? Yes, we are recording, so it will be available probably in about a week after tonight, when we get things edited and ready to go. The other bit of housekeeping that I have is that we wanted to thank our funder, who is the Advancing a Healthier Wisconsin Endowment through the Medical College of Wisconsin. We have been in partnership with the Medical College for this series of programs, and we are thrilled to be working more formally together, including with Annie, who has been a joy to work with, even though she's way overbooked and I think is doing this on her free time, which makes me even feel worse, but you're fantastic, so thank you. I'm going to turn it over to you, Annie, to get us rolling. If you can share with folks a little bit about who you are, and I will track the comments and questions, and then we'll come back together and do some Q&A. Cool.
Right. Thanks, Michael. I want to start out by just saying that this is my pleasure and joy to be with you tonight. This is something that I feel passionate about, and I appreciate being invited to talk. So I'm Annie Lakatosh. As Michael mentioned, I have been a nurse practitioner for over 10 years. I've been a part of our inclusion health clinic at Frederick and the Medical College for the last 2 years. And so tonight I'm going to be reviewing the topic of hormones and transmasculine hormone therapy. I do recognize that some of you may already be on hormones, some of you may be interested in hormones, and so this is really my approach of saying this is an introduction and also a platform to ask questions. My perspective is really coming from a provider perspective, and I think that's an important piece to remember. Also, as a nurse practitioner, I am not an endocrinologist nor a gynecologist, so I'm going to be giving just really kind of the bird's eye view of information tonight. And so if there are questions, I really, really would like to hear those. Also some feedback. I really appreciate those as well. So getting started. What we're going to do is we're going to review the current guidelines that are out there regarding testosterone therapy, as well as masculinizing hormone therapy. We're going to talk about how to get started. And this is really from my perspective of the Inclusion Health Clinic. And we're going to talk briefly also about what you may experience in other clinics. What do you expect from those appointments? We're going to talk about the effects and the risks related to masculizing hormone therapy. And then as a primary care person, I can't help but talk about health maintenance as well. So we're going to finish up the talk with that. So just to start out, if anyone was a part of the talk about feminizing hormone therapy, you're going to see some similarities in tonight's talk. And the first is definitely that not all sources on the internet are created equal. So I like to tell that to my patients, because I really want to enable them and empower everyone with the right information, and information that has been supported by data and research and practice, clinical practice. I want to also mention that the guidelines that we're going to talk about tonight really are guidelines. They're not a recipe or a way that is applied to every single person exactly the same way every single time. So it's important to develop a relationship with your prescriber, your provider, who's supporting your transition and your journey, and really to say what makes sense now, what makes sense, in 6 months, or what are our ultimate goals. I also want to just make mention of some of the national leaders that we have in the United States about masculizing hormone therapy, and they're all listed on your screen, including Fenway and Callan Lord, which are located on the East Coast. Our endocrine our endocrine society, they have guidelines that also support this process. And then we're going to review the University of California, San Francisco Transgender guidelines, as well as the World Professional Association of Transgender Health, the WPATH standards of care as well. So this is something that I've brought up in the past, and this is where we really focus on the expression of gender in an insistent, consistent, and persistent manner. And so this is from the Endocrine Society guidelines, essentially, and this is what I like to focus on in terms of people who may be interested in starting hormone replacement therapy. There may be some questions about whether or not they're eligible for HRT, or if this is something that could be applied to their healthcare. These are some of the recommended requirements in a way. I don't want to use the word requirement, but this is outlined in WPATH as well and supported by them. Okay, and so WPATH really does come from a perspective of psychiatry, and it was developed in the guidelines that are currently available are from 2012. And these will hopefully be updated sooner rather than later. There were some efforts made last year, and with the coronavirus, that has most likely been placed on the back burner for a period of time. What I like about this document, and it's a very large document, is that it gives some really straightforward charts on the effects of masculizing therapy, as well as some of the risks to consider if you are starting masculizing therapy as well. And so on this slide, you can see kind of where to access those charts. We are going to review those tonight. So the University of California, San Francisco, these are my favorite guidelines. They're very robust. They're backed up by clinical practice, by data, and by ongoing research. And so this is a site that I will often bring patients to when I'm in an exam room with them to say, this is what I want you to take a look at. And I oftentimes will literally just get on the internet and say, this is how you find it. Because I want people to know that they're very accessible. This is a great way to find information about hormone replacement therapy, but also about additional health topics that are very pertinent to the transgender community. And so we've got the hormone replacement therapy recommendations, and we'll review those tonight. But it also gives some information about the nuances of the medications that are recommended, essentially. And as a primary care person, it does also guide me through things such as bone density recommendations, and how do we address cervical cancer screening, and how do we address breast cancer screening. And so that's really important to know and to stay on top of in terms of that knowledge base. The other thing to consider is that sometimes symptoms may manifest, they may crop up over time, and they may be expected, they may be unexpected. This is a really good website to go to if you are having some symptoms that you're concerned with, just to access and say, what's going on here? How concerned should I be? I would definitely encourage you, if you are accessing this site for symptoms, to also be sending your provider a note as well, to let them know what's going on, so that they too can share their experience or their recommendations, and to work together for resolution. Right. So this is what the website looks like. Dr. Deutsch is a researcher and physician that really is the driving force behind these transgender guidelines. She also happens to be a transgender woman, and she is a very dynamic human being and is really looking at new research out there, things such as PrEP in the presence of HRT, and is there any effects to that that need to be noted? I mean, she's really a dynamic person. And I like this because it really just gives you the recommendations on the left-hand side of your screen so that you can easily find what you might be looking for. So how do you get started on hormone replacement therapy? The last time that I had talked, I had mentioned, you need to start with finding a clinic or a provider. In some ways that we do that is talking to our friends, community members, even accessing some of our community resources and groups. And I would say that that continues to hold true. You want to make sure that you're getting some feedback from people that you know or that you've heard of. The other thing is sometimes people can have some different experiences with different providers. I would just say, ask those questions, call the clinic up and say, I'm looking to establish care. What do I need to do to make that happen? And really get a feel for those clinics. There are a couple of different types of clinics out there. And I'd like to just mention that I am coming from the perspective of the Inclusion Health Clinic. So I have that one perspective. And some clinics are informed consent clinic, like the Inclusion Health Clinic, and you don't need to have a letter in order to get started on masculinizing hormone therapy. It would just require a conversation with the provider that you see, and we'll review what you might expect from that first visit. There are also other clinics that are non-informed consent clinics. So in that situation, you would more than likely be required to have a letter from a therapist that states that you have been diagnosed with gender dysphoria and are eligible for hormone replacement therapy. So this would be an important question to ask when you do call a clinic to, clarify if this letter is required. The other thing that a couple of patients have brought up to me is that the expectation of starting hormone replacement therapy on that first visit is not always well known. And so that's also a good question to ask when you do call a clinic and say, is it likely that I would start HRT on this first visit, or is that something that has to happen at the second or third visit? So that would be good to know. And then finally, it's really important to just come to your appointment. I have met many people over the last 2 years of being in the Inclusion Health Clinic, and there has been a certain level of nervousness or anxiety or fear. And I would say that that's very okay. And one of the best things that you can do is come to that first clinic appointment and get the feel of your provider and get the feel of the clinic and see if that feels good to you, because that will be a place, a home, really a healthcare home for you, so that you can start your journey together. And then I think it's important to ask yourself, what are your expectations when you do see your provider for the first time? Are you looking to have a certain gender provider? Do you feel more comfortable in a certain circumstance? And also, there are clinics out there, the Inclusion Health Clinic being one of them, that offer virtual appointments for that first, clinic visit or subsequent visits thereafter. And so those options are out there, especially with the COVID-19 pandemic going on, that would be something to also consider. For the patients that I've met just as a telemedicine or virtual visit in those initial, in those new patient visits, it's great to meet each other in person, because I think that's when you really get the vibe of someone. But it's really great to get started on HRT if it makes most sense to do it virtually as well. Okay, so what does your first visit look like? These are the questions that I ask my patients, and I know that a number of the providers in the Inclusion Health Clinic will ask their patients as well. And so, when did you first identify as being a gender other than the one that you were assigned to at birth? And I would say helpful to know how long the process has been going on, both in your mind and your heart, so that we can help support that journey as well. I know a number of patients have been waiting 14 years, and that's a long time. Other patients have been waiting less time. Other people have been waiting less time. It doesn't matter. We want you to come in so that we can start that journey with you. Another question is, how long have you been living as your gender? So some of these questions, I will tell you, there are no wrong answers. So if you're concerned about the longevity of your journey so far, again, it's important to share so that we can help support moving forward in your journey. And then what kind of support do you have from friends, family, other community members? And this is really just to better understand what your structure of social connections are in your life, so that as you progress in your journey, in your transition, that we know that you have people around you to help with that. Sorry about that. And then, have you ever taken HRT in the past? That's important to know, simply so that if you are getting any HRT off the internet, we can at least get some labs and understand where you're at that point in time, or even just to address any questions that you might have about the products that you've received online. And then, what are your goals? Where do you want to be in a year, in 5 years, in 10 years? Some people will have been on HRT for several years by the time that I meet them, and so I'm kind of coming in midstream there. Other people will have just started their journey, and yet other people will just be coming in for questions and answers and just to have the conversation, not to start HRT at that point in time. And that's all fair game. That's all a really great way to get to know your provider and also to better understand where you're at in your journey. Sorry. There we go. Okay, so in terms of the inner workings of your appointment, I had mentioned this earlier, there are no wrong answers whatsoever. So it's all about better understanding where you're at this point in time in your life, where you want to go, and how do we help you get there. I've mentioned, several times, where do you see yourself? Where do you see yourself, in 6 months? Where do you see yourself in 5 years, 10 years? Where do you want to be? And then how can we best help that transition and your journey moving forward? Some folks will say that they're not too keen on, presenting completely masculine. That's completely okay. Just let me know where you're at with that. And that's why it's really important to understand what the recommendations are regarding medication management, so that you feel confident that you're getting the medication that you need to start your journey or to continue your journey. The other thing that I like to include in the conversations I have with my patients are, what are those expectations about appointments moving forward? So oftentimes for me, in the first year after starting hormone replacement therapy, I like to have people come back every 2 to 3 months. And that's to address labs, to see how they're doing, to make sure that if any other concerns, questions crop up, that I can help address those as well. In that first year, I anticipate seeing people about 4 times. After that, once we get to a maintenance dose and things seem to be coasting for a while, we would see each other less often, so maybe every 6 to 12 months. Definitely, in terms of primary care, I would want to see you back if anything else crops up or any other health concerns crop up. When you are being seen in an appointment, we do look at your blood pressure. We look at whether or not your weight has fluctuated. That's not to really look at that number. It's really just to look to make sure that you are, that there isn't something related to the masculizing hormone therapy that we need to address. And then really to say, how are things going and where are you at? Is there anything else that we can do? Oftentimes I'll talk to people about 6 months into it, maybe even 3 months into their journey, about surgeries. And that's not in the scope of this talk. I can certainly answer questions if people have those at the end of the talk tonight, as best as I can. But that's oftentimes a part of the conversation. Do they want a referral for a consultation, or what are their thoughts about different gender affirming surgeries? So let's start talking about what to expect with masculizing hormone therapy. so this is very exciting because really what I see this as a life-affirming process, and testosterone being the backbone of masculizing therapy is really an opportunity to align your gender identity, your gender expression. And so I like to tell people that they'll be going through a puberty, another puberty. And so if anyone remembers their first puberty or may not be that distant from it, we'll have that opportunity again. And then we also anticipate those desired effects and changes that we'll be going over in the next slide. So really it's the things that we want to be seeing, those physical changes, also some of those emotional changes as well. It's important to know that with testosterone, your fertility or your ability to have biological children changes. So it doesn't completely wipe it away. In fact, Dr. Deutsch and the University of California, San Francisco, and the team there are looking at fertility options for folks that are on HRT. But it's important to have that conversation now so that you're aware of what your options are. And sometimes people, pursue egg preservation, which is great. It can be cost prohibitive. That's one of the drawbacks of that process, but it's an important conversation to have with your provider. Alternatively, testosterone is not a form of contraception. And so one of the things that we want to avoid is an unintended pregnancy while on testosterone. So it's also important to talk to your provider about any contraception that makes best sense to you. And at this point in time, in terms of all the options that we do have available, we tend to use the progesterone-only forms. And that includes Depo-Provera, which is an injection, Nexplanon, which is the rod that's placed in the non-dominant arm, just a superficial placement, or an IUD. And those would be accessible at many clinics, including the Inclusion Health Clinic. And then I had mentioned this, to really establish the frequency of appointments so that you know what to expect in that first year, especially. And you can also say, I'll see you in November, and this is what I'm hoping to see in November. I'll get my labs before that appointment, or I'll get them after, and then we'll talk about them at whatever time makes most sense. But the important thing is to recognize that alongside testosterone is the tincture of time. So time will continue to work with you in terms of your transition. When people are on a maintenance dose of testosterone, they will continue to see changes that despite not changing the dose of testosterone, but under the influence of T, you definitely will continue to see changes that we're looking for as well. All right, so this is a chart of the effects of masculizing therapy. And so this is from WPATH. It's, I want to say, on page 37. But these are some of the effects that you can anticipate. So there will be some skin changes, including some potential increase of acne. And we start seeing that in the first 1 to 6 months, with a maximum effect of 1 to 2 years. We also start seeing facial and body hair growth. So hair will become denser, a bit thicker, and it'll occur on the chest, the back, the upper thighs, your arms, legs. And that starts 3 to 6 months after starting HRT, with a maximum effect of 3 to 5 years. We do see some scalp hair loss, so that's variable. That's very dependent on genetics. And I would say that that's one of those side effects that we know will happen, and we can certainly help address that if it's not completely desired with other medications or by adjusting your T dose. We see increased muscle mass and strength. A number of people will start working out with weightlifting really to tone those muscles up, and we see that in the first 6 to 12 months. The body fat redistribution, so oftentimes the hips will kind of box in a little bit, and the chest will change as well, and so there will be more of a boxed look to folks. And then importantly, the cessation of menses. So we do anticipate that the bleeding should stop by 6 months after starting HRT. We'll review that in a little bit, but that's oftentimes a question that people will have about the effects of HRT. That, I would say, to continue to keep us close as providers so that we can help address any concerns that crop up with that. We do see bottom growth, so clitoral enlargement will occur in those first 3 to 6 months with a maximum effect of 1 to 2 years. Alongside that, we see what's called vaginal atrophy. So that's where the vaginal vault, or what we call the vaginal vault, will actually, the cells will actually become a little bit drier and maybe more prone to bleeding. And that may be an effect of testosterone. It could also be an effect of something else. So if someone ever has that effect, I definitely would want to hear from them. And then a deepened voice is something that we also experience. I actually saw a patient recently and hadn't seen them in 3 months. And I first thought was, your voice has changed. And that's exciting for me because I don't see people on a daily basis. So I can see those changes maybe a little bit more rapidly. But we do see that deepened voice occur in the first 3 to 12 months after starting HRT. Okay, and so how do we get that testosterone? There are currently 3 options. The one thing I didn't put on here is that the FDA recently, like I just heard about this, I want to say within the last 3 weeks, approved an oral testosterone pill. I would imagine it's about $1 gazillion right now. So until that has had some time on the market, that's not on our list tonight. So the injection is a very common way to receive your T. We do prescribe this to be taken every 1 to 2 weeks, depending on people's preferences. Sometimes some discomfort around that injection site can occur, and so we do, recommend changing those injection sites every time that you administer the injection. There's also gel, and that's a daily application. We recommend putting it up on the upper arms or shoulders and allowing it to dry for about 2 hours. If you do anticipate close contact, and this is what the recommendations are, if you do anticipate close contact with women or children, it is recommended that it's washed off. But oftentimes people will apply it, allow it to dry, and then cover it with a shirt. And then a patch is also out there, and that's used on a daily basis as well. And so depending on what your preference is, what you feel most comfortable doing alongside insurance coverage, that's really what tends to dictate where people go with these options. So one thing I hear a lot of things from my patients, and I really want them to tell me things so that I can answer those questions or find those answers for them. But the first and foremost, I hear from people that this is great, that this is all good. Things are feeling good, and this is the right thing. And I think based on our conversations before we start HRT, that is the anticipated effect that we discuss, but it's always good to hear that. I would say acne is another thing that comes up, and I would just recommend people treat acne like they would typically, and that's to start with over-the-counter products. And if that's not working, definitely let your provider know so that we can help support that treatment as well. And there are topical treatments, there are oral treatments out there as well. And that might change also. I think in the first 3, 6, 9 months, you may see a number of physical changes occur, and it's important to keep an eye on it, but also to allow your body to go through them. But then we need to address anything that is not desirable, and sometimes acne can be one of those things. And then, is hair loss really going to happen? So I would say that this is something that is dictated again by genetics and also by time. And so we can't really say, yes, this is going to happen to every single person who starts T. It's just a consideration, and to recognize that this may be part of your journey. And then finally, bleeding. So bleeding is something that can occur past 6 months. It's rarely reported, I would say, or it's infrequently reported, but definitely I would want to know. And that might be related to the use of gel. Gel is a great option for folks. It's daily use. When we get people started on gel, it might just take a little longer for the cessation of menses to occur, so to stop that bleeding. So it might just take a little bit longer. Again, if you do experience bleeding after a period of time without bleeding, that would be a phone call, just to talk about what we should do about it. And I can get into a little bit more detail at the end of the talk if anyone has questions about that. So alongside the effects, and again, WPATH and UCSF really have them outlined well for us. We also want to talk about some of the risks that are associated with the hormone replacement therapy. And this is where obtaining a health history or sharing your health history with your provider is helpful, because we want to know if you have any cardiovascular history that we should be aware of. We also want to know if there are any what we would consider risk factors just to be aware of. So it wouldn't necessarily negate you from starting T. It would just be an important piece to understand. For example, to have a person start hormone replacement therapy in their 5th or 6th decade of life, completely reasonable, but we would definitely want to know if there are any underlying health concerns that we should be aware of that might change our recommendations in terms of the path that the medication is delivered. So if it's an injection versus a gel, for example. The other thing to know is that when we start looking at your labs, we will be looking at them through a particular lens. So as amazing as our electronic medical records are these days, sometimes things can get a little bit out of focus if we have a sex assigned at birth and a gender that are not congruent. And so as providers, our job really is to be able to interpret those labs appropriately. So if you do have any questions about your labs, don't hesitate to reach out to your providers. And then as always, and this I would say should be a basic expectation of every person seeking healthcare, and I feel very strongly about that, is that your preferences and your goals should be incorporated into the decisions that you're making with your provider. So there shouldn't be a dictating going on any level, but you should definitely keep your provider up to date in terms of what your goals are so that we can help support those. So regarding those risks associated to testosterone use, the top 2 points are really the pieces that I focus a lot on with folks. So polycythemia essentially means that there's an increased hematocrit and hemoglobin. So there's an increased red blood cell count. We can become polycythemic if we're dehydrated. So if you've been outside working hard, sweating, your red blood cell count just becomes a little bit higher than the fluid in your body. And so that would be I would say an expected finding if you're dehydrated. We also see those counts go up with testosterone. It doesn't mean that they will, but we do just keep an eye on that, and that's part of the routine labs that we get. The other thing to consider is that there are considerations for weight gain, acne, balding, we've talked about those things, but also sleep apnea. And so that's really in our wheelhouse to say, are you having more snoring, or has anyone told you that you stop breathing at night? Or are you falling asleep, just sitting in the waiting room for me? Or are you falling asleep in your car? Those are all things that you want to let your provider know so that we can screen you and potentially refer you to a specialist to take a look at that. Other risks that might be involved are just elevated liver enzymes. So again, we take a look at those, and there might be just a slight blip up, and we'll keep an eye on that. We also then would recommend further evaluation if it's significantly high. Some medications and certainly alcohol can also increase liver enzymes, so it's just something to have on the radar. And then high cholesterol is something that we keep an eye out for as well. So you may be asked by your provider to fast for a certain set of labs. We get the best results at this point in time. That's what's recommended for our cholesterol screening levels as well. There is a potential, this is our third point here, there is a potential that with testosterone use that there may be some changes in any depression, anxiety, or other mood disorders that may be present. This isn't to say that if anyone has depression or anxiety that they shouldn't be started on T, quite the opposite. In some circumstances, that depression and anxiety is related to gender dysphoria, and this would be one of the treatment options that we would recommend. However, T can be very activating, and so we may ask you questions about your mood, and I want you to be honest about those just so that we can at least address them, help and give the recommendations that would be most appropriate for you as well. And then we also do see some potential increased risk of type 2 diabetes, high blood pressure, and cardiovascular disease. So, and those all really get into health maintenance, which we'll be talking about shortly. But it's all about making sure that you are, eating fruits and veggies every day and getting some exercise and taking care of your body. And then finally, there is no known increased risk of breast, cervical, ovarian, or uterine cancers. Screenings are still recommended, and we'll talk about that briefly. But in terms of your ultimate risk, there is no increased risk to those. And then loss of bone density is also not been shown to be an effect of testosterone therapy. Again, bone density evaluation is something to talk to your provider about, and what age makes most sense for you to have that done. So you've started testosterone, or you've been on testosterone for a while, and it's amazing. It feels good. But what happens if you do want to change your dose? You want to stop, or you want to slow down, or the opposite, you want to increase your dose, or you want to speed things up? Have that conversation with your provider. Let them know where you're at with that, because I think it's most important that we align those goals and preferences and that we don't miss something. It takes a while to get used to your providers. I think that building that relationship also takes time. And so make sure that you keep them, abreast of what's going on in your thoughts, what your goals are, what your concerns are, where do you want to go? And that's possible. You can do that. So I have a patient actually who is doing great in their maintenance dose, and he is looking at actually reducing that dose per his preference. And I think that makes a lot of sense if that's where he's at in his journey. And then what happens if you don't feel well on HRT? So I've had a couple of situations with patients who, for a variety of reasons, haven't felt well. And I use that very vague term. Again, I want you to reach out to your provider in that case. And I really encourage my patients to keep me posted as to what were their symptoms so that we can talk through that. Is it something related to HRT, or is it something different? And again, it's all about building that bridge and that understanding so that we can continue to support your transition and your journey forward. And I've mentioned this all throughout. It's really important to talk about health prevention and wellness. And so one piece of our appointments are oftentimes to do an organ inventory, what we call an organ inventory. And that's really looking at the body as a temple and what organs are in your temple. So if you still have a cervix and you're older than 21, that cervix needs to be attended to. And what does that mean? That means that you should have a conversation with your provider about cervical cancer screening. This is a particular interest of mine, especially in our trans men. I think that cervical cancer screening can be very dysphoric and very off-putting for a variety of reasons. And so have a conversation with your provider. Is there an alternative method to have that screening done? And there is. Breast cancer screening is also something to consider for anyone who has not had a double mastectomy. What does that mean? Do I need to have a mammogram? What should I be concerned about? Have that conversation with your provider. Lung cancer screening, I would say for anyone who smokes or uses tobacco products, it's always a good idea to try to reduce that use if at all. If you can at all, just stop it entirely. And that's important for a variety of reasons. Number one, your health is going to improve. Your risk of cancer is going to go down. But also if you're looking at a surgery, that surgeon is going to ask you to stop smoking as well. So it's really an important piece to the puzzle there. I mentioned earlier bone density health. It's something to be aware of. We do start screening people about 65 years of age unless their hormone levels have been on the lower side. And then sexual health is also an important consideration. Have a conversation with your provider about what makes best sense to you in terms of your sexual health. How do you remain sexually active in a safe and healthy way? What are the tools that you use to do that? And that might mean contraception, that might mean PrEP, and that might mean just screening on a routine basis as well. And then it's important to be up on your immunizations. Definitely with the COVID-19 pandemic, we're recommending flu vaccines for everyone moving forward, and that should start after September 1st this year. But in addition to that, you want to make sure that you're getting your human papillomavirus vaccine, you're getting your hepatitis A and B vaccines as well, and that you're up on those. And then finally, the exercise and activity. So with the coronavirus pandemic, many of us have been inside and working from home. I would encourage everyone to get outside and walk. That's one way to get your steps in, but just to get your body moving. Definitely with the rain today and then with the humidity, that can be a bit challenging, but we're just about to hit fall. So I encourage everyone to get moving outside as well. So that concludes my presentation tonight, and I'm hoping that that we can now have some time for questions.
So thank you for the great presentation. There have been a lot of questions. Some of them have been kind of public and some of them have been private. So why don't we start from kind of the top down in the questions? So one of the first questions was, given the evidence of multiple internal sexual systems beyond endocrine and organs, how are hormones calibrated to the individual?
Ooh, that's a good question. So at this point in time, we really just have a range in terms of where we start with our testosterone. We have a starting point, and that starting point can either be lower than that recommended dose, or it can, I would say, or a little bit higher depending. It's really important to start at the guidelines that tell me where to start people at. So for example, testosterone cypionate, 50 milligrams once weekly. That's a very typical starting dose. Some people don't feel comfortable with that, so I'll go down a bit. But at 50 milligrams, that gives us a place to start. And then we start looking at what happens in your body and how does your body process that, and then how can we either increase it or decrease it depending on what your response is as well as what your labs are. So, but no pathophysiology tonight, unfortunately.
All right, cool. So this is a little bit, it's similar to the previous question. So is hormone recalibration in any way correlated with long-term effects, such as increased incidences of cancer, whether or not organs are retained or not? Is it recommended if born with a uterus and ovaries that retaining them decreases other health risks?
Great question. So testosterone is a safe medication when taken as prescribed. And I tell my patients that this conversation that we're having today is very different than it would have been 10 years ago. And I anticipate it'll be different yet again in 10 years forward. As it relates to internal organs, so there I would say are some benefits of keeping ovaries truthfully in our trans community. I would say probably not. Like especially if it's a source of bleeding or discomfort, that hysterectomies are done. And what happens now is that a hysterectomy is done and the tissue is actually tested to make sure that there isn't any pathology that has been found, because then we just negate the whole cervical cancer screening moving forward. I mentioned, and I also want to say our ovarian cancer screening methods are some of the most pathetic methods out there, and that means for everyone involved. So really to make sure that if you want to go down the path of having a hysterectomy, that's a great option if it makes sense for you. It's not required, and there is no known risk of cancers with TEAT as well. So hopefully I answered that.
Next question is a physical pelvic exam or any hormone measurement required as a prerequisite for changing gender marker on ID?
Great question. Absolutely not. Absolutely not. So the other thing, and I've been like itching to say this too, so I apologize, because for some reason this is a trigger for me. No one should be held, your testosterone should not be held or made ransom if you are due for cervical cancer screening. Those are two very different things. And so that is, I've heard that from people and I'm horrified by that. So absolutely not. Pelvic exams are not necessary unless there is a concern or there's a screening that's recommended. And again, I'm happy to talk about self-collection of cervical cancer screening, but it's not a prerequisite at all.
That's cool. And that might be a great place to go, because there were a couple of questions about, can you talk about PAP alternatives?
Yes. So
Let's go there.
So, and I think I've told this to Michael, I'm in school for this, I'm getting my doctorate, and I'm really focusing on how to get cervical cancer screening a little bit more prevalent in the trans community, because it can be so dysphoric and uncomfortable for folks. So there's data out there that suggests that self-collection is actually very effective. And there are two things that we look for when we are doing cervical cancer screening. One is to look at the cytology, or the cells on the face of the cervix, as well as the cervical neck. So the cervix looks like a tiny little donut, and there's a part that's called the endocervix, and that's what we want to also test for. So we're looking at that, and then we're also looking to see if the human papillomavirus is present. Studies have actually shown that with self-collection, and you're using the same soft tipped brushes that would be used by the clinician, there's a better yield of HPV results when it's self-collected. So that's a good thing. And then there's not clear data about whether or not we absolutely need that endocervical, or that component in that cervical neck. And so it's a really great option for people who would otherwise not have cervical cancer screening done at all. The other piece to that is that clinicians, when we go to school, we don't get specifically transgender education. That's changing, thank God. But I would say that to have a clinician that knows kind of how to navigate that is really important, but also to give you that option. You would get the swabs, you would stay either in the exam room or go to the bathroom, and it literally is a 3-step process. And which is very exciting, because again, when people have some increased risk, so anyone who smokes would have an increased risk of cervical cancer. Anyone who, their sexual history does have some role in it, because it's exposure to the human papillomavirus, or HPV, but it's important to have that conversation with your provider so that they can guide you through that.
That is really cool. I think you're the first person that I've ever heard talk about an alternative. So I bet that makes a lot of people happy that are listening tonight. The other question, and I thought of this as well when you were speaking, is what about testosterone pellets?
Ooh, yes. So that, I would say, is probably, so when you start hormone replacement therapy, or you see the average clinician like myself, that would be something definitely that some like specialists would most likely be able to offer that. I don't know if our inclusion health folks do it. I've not heard that they do it, and I can certainly get more information about pellets, because that, especially with those injections are amazing, but I have heard from people that after some time, it becomes a little bit cumbersome, and it's a little bit of that discomfort with that injection. So pellets might be a really great option for folks as well. So I'll get to
some people really love it because it's like a 4-month, thing. You don't have to worry about it for many months, and that can be really helpful. Let us move to the next question. So on slide 16, you talked about risks, and this person is asking, are there any dietary or fitness methods to counteract the risks? Or are we just like fighting the uphill battle of science?
No, so I would say at the end of the day, you always want to be, leaning more heavily towards being a physically active human being, and having food choices that are more like unprocessed fruits and veggies, whole grains. And that's not just because of tea. And I also want to just point out that in terms of risks, so weight gain is actually included in both the feminizing hormone therapy as well as the masculizing hormone therapy. So what does that tell us? That tells us that we're all at risk for weight gain, I would say. And so it's just really important to know what your food choices are, what those consequences are. People probably have heard me, I know, Michael, you've heard me say there's always a time and place for Cheetos, but it's really important to keep things in balance. And so there are great recommendations, of doing a food diary and really understanding where your calories are coming from. So, yeah.
The next question is from a provider who's asking, do you see much elevated bilirubin?
I see. That's a really good question. I actually have not. I've seen just recently some upticks of like AST and alkaline phosphatase, which are liver enzymes. I would say that in the situations that I see them, they're very mild. So I'll just keep an eye on them. In one circumstance, it was actually considerably high, and it was actually being caused by another medication that they were taking. So it wasn't testosterone.
So the next question is, I'm guessing might be something that you're going to say, well, I don't know the answer to, but I would love it if you did. So does insurance coverage of healthcare screenings for cervical cancer and breast cancer change with transitioning legally? So if you become legally male, will insurance still cover screenings for body parts that you still have?
That's such a great question. And this is where you can really leverage your provider. This is their job also to advocate for you and say, you have a cervix and that needs to be attended to. And so your provider should be able to give evidence that, yes, this is pertinent. I mean, literally, I just wrote a paper on this, so I'm happy to give that to people. But I would say, truthfully, it should be covered by insurance because it's a preventative measure. So, yeah.
And just, to add to that, like some parts of the Affordable Care Act, Section 1557, which is being threatened to be rolled back, also includes, like, if you have the parts, all of your parts should be covered. So sometimes it's hard to work with your providers to get that to actually happen, and to work with insurance companies, which is the harder part. Next question is there any interaction between testosterone and psychiatric medications?
Not that I've seen, and a number of my patients, for a variety of reasons, are on different medications for mood and or psychiatric medications, and there shouldn't be any reason not to combine the two.
Okay, cool. So someone is asking, do caloric intake recommendations change from female to male recommendations when on testosterone?
Good question. So I would say, if anyone has ever taken a look at a label and it's like based on a 2,000 calorie diet. So I'm not sure any of us should be on a 2,000 calorie diet, truthfully. So we're looking at our activity level, our height, our ideal weight, whatever that looks like. And so I would say that it all gets down to, where do you want to be? How do you feel? And does that make most sense? So there's a question about, how much does a pound of feathers weigh compared to a pound of stone? Well, in muscle mass, muscle actually does weigh more than adipose tissue or fat, and that's just because it's denser. So you could see an increase of weight, not necessarily of girth, but just of muscle tone. And so that's something to be aware of. And I would also say that it's important really to understand where you're at in terms of your physicality and where do you want to be. And and I would say generally we all need to be walking more, all of us. So.
Right, exactly. There's many other interesting questions still. So another question is, if the uterus and ovaries are retained, how is perimenopause and menopause affected? Yeah. What is the aging change in the 50s and older look like for trans men?
Great question. So just in general, menopause tends to occur as it would have, it mimics your mother's menopause. So we can't oftentimes say, this will happen just like your family members did. In this situation, on average, menopause happens between ages 50 and 52. And so at that stage of the game, things are pretty shrunken and pretty just kind of hanging out. Under the influence of testosterone, everything should also still be pretty minute and shouldn't be causing much problems whatsoever. In terms of symptoms, like really, because you're not having that typical hormone, I don't want to call it typical, but that expected like effects of estrogen and then the lack thereof, you've been on testosterone for a while or maybe more recently. And we can certainly address hot flashes that may occur or any symptoms. At the end of the day, my major concern is if anyone has vaginal bleeding, they absolutely need to tell someone. So I've had one time, and it was one too many times, that was the case and it wasn't brought up, and that had a bad outcome. So I want to encourage people, and it might be embarrassing and it might be hard to navigate that. Find a clinician that you can share that with if that's occurring for you. So, but when it comes to T and with menopause, I would say you continue doing what you're doing until you don't want to anymore, or you feel that less is appropriate as well.
Excellent. So this kind of goes back to the beginning. So does the initial blood work show the existing level of testosterone in our bodies? And do you go off of that number for planning the dosage?
Good question. So I don't, and I mimic what I would say the inclusion health clinic providers in general do this. So this is, I'm biased, so I apologize, everyone. But in general, I don't order labs at the time that I start HRT. I anticipate that hormones are where they are, and then we just go from there. So unless there's other underlying medical conditions that might change those hormones, I wouldn't routinely get a baseline. That first set of labs would be 2 to 3 months after starting T. And then I would go from there to say, where are we at? And we're looking at estrogen coming down, and we're looking at testosterone coming up.
And there's like this huge range for normal testosterone levels, right? So it's like, even if you did take a screening at the beginning, it might be higher or lower, and
yes,
there's this huge range.
Absolutely. And early on, I remember someone saying, I feel the best when my T is at 400 or at 600. And I think that was so valuable to hear, because then I can be like, all right, that's where we need to be, or that's where we're going to shoot to be. So that's not the case for everyone, but yeah, you're exactly right.
I don't sweat as much when my testosterone is lower, or whatever some of those things are. It can be really amazing just to titrate a little bit.
Yes.
So someone is asking, and this is a great question for your next presentation in a month, is it possible for a middle ground with T for someone who identifies as non-binary rather than going fully towards masculine?
For sure. And I have a number of patients on that path. Absolutely. And that's where I think it's beautiful that you don't have to increase. You can hold steady. You can start and hold steady, and you can hold steady for months or years, whatever makes most sense. And you're right, I will definitely review that in September, but you don't have to keep plowing ahead. And I had mentioned a patient who was at their maintenance dose, and he's like, I'm good. I think I'm going to go back to this dose where I felt really good and I got the effects I was looking for. So
Nice. So I had thought about this as well when you talked about hair loss. Some of us have that. Can you talk about Propecia? And does it work? And does it negate testosterone use?
Yeah. So I would say that, and I've asked the endocrinologist that we have in Inclusion Health just to say, like, how do you navigate that? We'll oftentimes start with topical agents just to assist with hair growth. And in some cases, I'll actually send people to dermatology just to say, what else? Testosterone to me is a life-affirming medication. So unless we, kind of change the mechanism of how it's delivered. So we might change it to a patch. That might change some of those effects that people can experience, or we supplement it with, Rogaine or something of that sort. So there's always an option. And I'll say that if someone came to me and said, this is what's happening, like I said, I would go to my endocrinologist and say, this is what's happening. What else can we do? Or what have you had the experience of? And that's one of the beauties of having a team of people that you can really bounce ideas off of. So
I'm aware that we have 2 minutes technically left. Are you able to stay and answer a few more questions?
Happily, yes.
Perfect. And I know if people need to leave, please obviously feel free to do that. But we'll keep on going for a few more questions and wrap up a little bit after 7. So the next question is, should the dose change with age to mimic the decrease in T in most cis men?
That's a great question. I would say that it can. And it really, even in cisgender men, people are getting testosterone supplements because of their energy level, because of their performance. There's a number of things that they're looking at. So it's a conversation that you should have with your provider about where your energy level is, where your journey is, but also how are you feeling? And does it make sense to taper back? And that's completely appropriate to do. So.
Excellent. So I love this next question. So when I work out, I get really hungry, so I eat more and gain weight. If I don't work out, then I'm not hungry and I eat less and I lose weight. Is it more important to be physically active or more important to be at a certain weight?
So I will tell you, my bias is that you should just be physically active. And I'll tell you that physical activity increases mental acuity, quality of sleep. It increases your HDL, which is the good cholesterol that you want high. It also exercises your heart, which is a muscle, and you want to make sure that that heart gets some exercise. Just like your biceps or your thighs or any other body parts, you want to make sure that that heart is being attended to. It literally, physical activity is not a silver bullet, but it absolutely can help the whole system function better. So yes, and it also increases mood as well.
Bonus.
Yeah.
Really
So
bonus.
people shouldn't be skinny. People should just be who they are and physically active.
And there, you did a webinar on that as well, so about size. So if folks want to see it, it's on our YouTube channel, which is really great. So talking about size is not the primary indicator of health and what we can do. There's a couple more questions that I want to circle back if we can. So the person is asking, not sure if it goes here, but on the non-binary subject, can breasts be reduced instead of completely removed so that binding becomes easier, and will insurance cover it?
Yeah, absolutely. So breast reduction can absolutely happen. And there are some, I would say, caveats to insurance coverage in that. But if a person is having what we call, or has pendulous breasts, or breasts that have, cause back pain or a variety of other musculoskeletal issues, that can oftentimes be covered under insurance. So breast reduction completely. I would say too, when it comes to binding, our primary concern with binding is just skin health. And so if you use trans tape or anything of that sort, it sounds great. But if you're seeing that there's skin breakdown, that's when we would want to help address that. But yeah.
So a couple of questions that came in privately were, what can be done about polycythemia? And this person went on to say that my provider recommended going to the blood center, but they won't take me because I have sex with men.
So I just looked that up recently, and yeah, yes. So polycythemia, and that's exactly right. So phlebotomy is what is oftentimes recommended. So in my experience, I've actually talked to hematologists about it, and because we know that it's most likely driven by testosterone, it would be, can we reduce that T ever so slightly, but still have the general effects? Is that an option? If it's not an option, then we hold steady. When we look at labs, oftentimes as providers, we'll see like the numbers in yellow. And so you might see that as well. And we'll be like, oh my God, that's out of range. How far out of range is it? And there are different ranges. Like the top end of normal is actually a little bit higher than what some labs will report as being, normal versus abnormal. So it's really important to have that conversation with your provider. The other thing is that sometimes polycythemia can be indicative of sleep apnea. So if you are having some elevated hematocrit and hemoglobin, it's, again, important to have a conversation with your provider so that they can say, is this being driven by something different than T? It might be T, but it might be something else. So
that's cool. And you mentioned like being dehydrated as well can
totally
cause that kind of fake
right. Absolutely.
And I know from anecdotal things, working with lots and lots of trans men over the years, that a lot of folks like with acne and polycythemia find that like injection tends to be like raising those risks a little bit higher than patches or gels do. So sometimes that can be a useful strategy just to change that format. Can we do a couple more questions? And this is kind of related to the format that testosterone is in. Someone says, my migraines have increased when I started on injections. My provider changed me to gel, which made my headaches go away. My insurance company won't cover androgel, though. Are there other ideas?
So my first thought is, could your provider do a prior authorization to say, we failed this one method and this is what happened, these are the side effects? So that might be the problem with prior authorizations, is that your insurance might say, great, yeah, we'll cover it, but only at this amount. So it still might be higher out of pocket for you. I'm wondering also if a patch would be something that the insurance company would offer as well. I mean, this is where it gets hard because you don't want to be on a medication and then have to take another medication to manage that medication's side effects, you know, and I would call a migraine a side effect from T, but yeah, that would be my first thought.
Yeah. And I know that, this doesn't work for everybody, but, now that androgel is in a generic form, it is cheaper than $1,000 a month, but it's still not affordable for a lot of folks. But sometimes people choose to do out of pocket just because it's a better method for them.
Right. And GoodRx is one resource that you can use as well for that.
So an interesting question here is, do I need to come in for injections? My former provider had me come in every 2 weeks and charge me for every visit.
No. So I'm sorry. No, absolutely not. I would say, so again, I'm biased. I apologize. Inclusion Health Clinic, we have nurses that will give you injection teaching. So you can give yourself that first injection or our nurse can do that for you. And then we're like, off you go. If you have any questions, concerns, give us a call when you're doing your next injection, or we can do a virtual visit to really navigate some of those issues. But absolutely, I would say you do not have to come in every 2 weeks for an injection. In fact, we'd rather you do it yourself because that's good.
Right.
Easier.
Yeah. It normalizes things, and there's no reason to have people running back in for.
Right. Absolutely.
2 more questions. So one is top surgery related, but let's go for that anyway. So for top surgery, if someone gets pregnant afterwards, or gains a lot of weight, would breast form again? So I'm debating getting top surgery before or after pregnancy.
Yeah, so great question. The thing to think about with pregnancy is that things change during that hormonal process, and if there is any retained breast tissue that was not removed during top surgery, which could be likely because they don't remove all breast tissue as they would if it was cancer related. So there might be some retained tissue that might grow during the pregnancy and beyond. I actually had a patient that happened to, and that they're now looking at a revision because of it. So it's just something to be aware of. Certainly shouldn't stop you from pursuing the pregnancy if that's what you want to do, or the top surgery either. And you can certainly talk to your surgeon about that to say, I'm concerned, how much do you typically remove? Are you fairly aggressive about that? But I would say in terms of weight gain in general, we unfortunately can't dictate where our weight goes when we do gain it. And so it will spread over your body most likely. And so that's just another consideration. If you lose weight after gaining that weight, then you'll likely see that in your chest as well. But there might need to be a revision done. So.
Those are, I think, all of the questions that have come in. So really fantastic questions, fantastic framing ahead of time. So thank you for all the questions. Thank you for all the answers. Really, really cool. I want to thank everybody again for being here, and thank you, Annie, for a fantastic job as always. And we always want you to come back and share more with us because you're just amazing. So thanks everybody for being here. You'll get an evaluation when we close out tonight. So feel free to give us your feedback because we care about your feedback. Thanks everybody.
Awesome. Thank you.
Thanks to our interpreters too.